Welcome to the deep dive. Today we're tackling a really important topic, gastric cancer or stomach cancer.
That's right. It's one we know can sound a bit heavy, but we're aiming to give you the clear, focused knowledge you need, especially for revision.
Exactly. Think of this as cutting through the noise, getting straight to the essentials. We've looked at the key info to help you understand it better.
And hopefully remember it too.
So in this deep dive, we'll cover the definition, what causes it, who's at risk,
How it develops, what else it might look like, how common it is.
the symptoms, how doctors find it, the staging, treatments, what to expect, potential problems. We've even got some memory aids lined up.
Sounds like a plan.
Okay, let's jump in. What exactly is stomach cancer?
So fundamentally, stomach cancer or gastric cancer is when you get this malignant growth of cells starting right there in the lining of the stomach.
In the lining. Okay.
Yeah, it begins in that innermost layer, the mucosa. And the critical thing is its potential to grow deeper through the stomach wall and potentially spread elsewhere.
Right, this uncontrolled growth.
Yeah.
So what drives that? What do we know about the causes?
Well, like many cancers, there isn't just one single trigger we can point to. It's usually a combination of factors.
Okay.
But a really major player is infection with Helicobacter pylori, H. pylori.
Ah, yes, H. pylori. Heard a lot about that.
It's very common, and it can cause this long-term chronic inflammation in the stomach lining. For some people, that environment just makes cancerous changes more likely down the line.
So that inflammation is key. What else?
Chronic gastritis, which is basically that long-term inflammation, is another factor. Then there's family history. Having close relatives with stomach cancer does bump up the risk somewhat.
Makes sense. Genetic links.
Definitely. Certain inherited genetic mutations can predispose people. And then, of course, lifestyle factors matter too. Things like smoking and specific dietary habits play a significant role.
So it's that classic interplay genetics, environment, lifestyle.
Pretty much, yeah.
Let's break down those risk factors a bit more then. Who is actually more likely to get this?
Okay, let's categorize them. Age is a big one. It's much more common in older adults, say over 55.
Right.
And actually, in the UK, about half of all new cases are in people age 75 or older.
Wow. Okay. Significant.
Gender, too. It's slightly more common in men than women. The ratio is around 1.8 men for every 1 woman.
Interesting.
And unfortunately, there's a strong link with poorer socioeconomic status.
And H. pylori again?
Yes, definitely circle back to H. pylori. Having the infection roughly doubles your risk overall. And there's a specific type, the KEGA-positive strain, which seems to increase that risk even further.
Okay, that's crucial. What about things we can potentially change, like diet?
Diet is hugely important. A diet that's consistently low in fresh fruits and vegetables
Right.
and high in things like salty foods, smoked foods, preserved foods, or things with nitrates, that pattern is linked to a higher risk.
So lots of processed meats, pickled stuff.
Exactly. And smoking, that's linked to maybe 20% of cases, so it's significant.
20%. Okay. Any medical conditions to be aware of?
Yes, certain pre-existing conditions increase risk. Things like atrophic gastritis, which is a thinning of the stomach lining, pernicious anemia,
Okay.
having had part of the stomach removed previously, post-gastrectomy, and a rare condition called Menetrier's disease.
And family history, you mentioned that earlier?
Yeah, about 5 to 10% of cases have a family link, especially in a first-degree relative. And we know about specific gene mutations, like in the E-cadherin gene, that are involved in some familial cases.
Got it. Anything else? Seems like a long list already.
Just a couple more key ones. People with blood group A seem to have a slightly higher risk. Relative risk is about 1.2.
Blood group A, interesting.
Also a condition called hypogammaglobulinemia, and higher alcohol consumption, generally defined as 3 or more units daily.
Okay.
Oh, and workplace chemical exposure, like in the rubber industry, has been linked. And finally, obesity, having a BMI over 30.
Wow. Okay, that covers a lot of ground. There's quite a few things to juggle. Is there a way to remember the main ones? A mnemonic, maybe?
There is. How about a GAS, HDS, FMBHA?
AGAS, HDS, FMBHA. Okay, break that down for us.
Here, A for age, G for gender, S for socioeconomic status, H for H. pylori, D for diet, S for smoking.
Okay.
Then FMB for family medical history, and blood group A, H for hypogammaglobulinemia, and the final A for alcohol.
A GAS, HDS, FMBHA. That's brilliant. Really helpful for recall. Okay, so we know the risks. How does it actually happen? What's going on at the cellular level, the pathophysiology?
Right. So it usually starts slowly. You have normal cells in the stomach lining.
Uh-huh.
Over time, these cells can accumulate damage to their DNA mutations. These mutations mess up the normal controls for cell growth and division.
Like the brakes failing.
Exactly. Good analogy.
Ugh.
The cells start dividing uncontrollably, ignoring the signals to stop. They pile up and form a tumor.
And then it spreads.
Then it can invade deeper into the stomach wall, and from there, cancer cells can break off and spread maybe to nearby lymph nodes first,
Yeah.
and then potentially through the bloodstream or lymphatics to distant organs. That's metastasis.
And those risk factors like H. pylori, they contribute to those initial DNA mutations.
Precisely. Chronic inflammation caused by things like H. pylori creates an environment where DNA damage is more likely to happen and perhaps less likely to be repaired properly. It sort of sets the stage.
Okay, that paints a clear picture. Now, if someone has symptoms that could be stomach cancer, what else might it be? The differential diagnosis?
That's a really key point because the early symptoms are often so vague. They can easily overlap with much more common, less serious things.
Like indigestion.
Exactly.
Yeah.
So the differentials include things like simple gastritis, just inflammation. Peptic ulcer disease is another big one.
Ulcers, right.
GRD, gastroesophageal reflux disease. Even other cancers nearby, like pancreatic cancer or esophageal cancer, can sometimes present similarly.
So you really need proper investigation to tell them apart.
Absolutely. You can't just assume based on symptoms alone.
Okay. Let's talk epidemiology. How common is stomach cancer, say, here in the UK?
In the UK context, it's actually considered relatively rare compared to, say, lung or breast cancer. In 2018, we saw around 7,300 new cases. That's about 3% of all cancer diagnoses.
3%. Okay.
And the good news is the incidence, the rate of new cases, has actually been decreasing gradually over the years here.
That is good news.
It mainly affects older adults, as we said, and slightly more men.
And globally, is it different elsewhere?
Very different. Globally, it's a bigger issue. In developed countries overall, it might be around 2% of cancers, but prevalence varies massively.
Where is it more common?
Much higher rates in East Asia, places like South Korea, Japan, China, also parts of South America.
Why such a big difference? Diet, genetics, screening?
It's likely a combination of all those things: dietary factors, H. pylori prevalence, genetic susceptibility, and importantly, screening programs, especially in Japan and Korea.
Right. And you mentioned a shift in the U.S.
Yeah, interestingly, in the U.S., there's been a trend towards cancers occurring higher up in the stomach, near the junction with the esophagus, becoming more common than those in the lower part, the distal stomach. Rates are generally lower in North America and Northern Europe and most of Africa.
Fascinating variation. What's the overall global impact?
Globally, it's the 5th most common cancer diagnosed.
Yeah.
But sadly, it's the 3rd leading cause of cancer death.
Third. Wow.
Yeah, it causes around 783,000 deaths worldwide each year. And again, men are affected about twice as often as women.
And that survival rate you mentioned, it's often diagnosed late.
That's the major challenge, particularly in Western countries. Because the early symptoms are often minimal or vague, it frequently gets diagnosed only when it's more advanced and harder to cure. The overall 5-year survival is often quoted around 15%, which reflects that late diagnosis issue.
Compared to Japan, say, with screening.
Exactly. Their screening programs pick up more cancers at an earlier, more treatable stage, which definitely contributes to better outcomes there.
That early detection piece is just so critical. So what are the actual clinical features? How does it show up?
Well, as we've hinted, in the very early stages, there might be no symptoms at all. Or maybe just some vague dyspepsia, indigestion, discomfort. About 70% might just have that initially.
70%.
So easy.
Mess.
Very easy. As it progresses, though, more definite symptoms tend to emerge. Things like persistent abdominal pain or discomfort, that just won't go away.
Okay.
Ongoing indigestion or heartburn, feeling nauseous, losing weight without trying.
Unexplained weight loss is always a red flag.
Absolutely. Difficulty swallowing, which is dysphagia, vomiting sometimes with blood, sometimes not, feeling really tired, fatigued, and early satiety, feeling full really quickly after just a small meal.
Feeling full quickly.
Okay.
And in more advanced cases.
If it's more advanced, you might see other signs. Jaundice, the yellowing of skin and eyes if the liver's involved, a site that's fluid buildup in the abdomen,
Right.
sometimes more obvious GI bleeding, though that's actually a minority, and signs of spread to lymph nodes like Virchow's node, that lump above the collarbone on the left,
Or a Chow's node, yeah.
or Sister Mary Joseph's node around the belly button,
Okay. And just to reiterate the demographic.
primarily affecting men, typically over 55. But remember, early symptoms are often absent or nonspecific, and things like PPIs, proton pump inhibitors for reflux, they can sometimes mask symptoms and delay diagnoses.
A crucial point about PPIs. So many present late with alarm symptoms.
Unfortunately, yes. a majority present when it's more advanced, with those alarm features like significant weight loss, persistent vomiting, maybe anorexia, abdominal pain, signs of anemia.
And are there things a doctor might find on examination that suggest it's quite advanced, maybe incurable?
Yes, certain signs point towards that. Feeling a definite mass in the upper abdomen, an enlarged liver, hepatomegaly, jaundice, ascites, finding that Virchow's node,
Uh-huh.
or sometimes a skin finding called acanthosis nigricans, those dark, velvety patches of skin.
Okay, so given all this, when should someone be referred urgently for investigation in the UK system? What are the guidelines?
Right, the referral pathways are important. An urgent suspected cancer referral, the 2-week wait pathway is definitely indicated if there's an upper abdominal mass that feels consistent with stomach cancer.
Okay, a palpable mass.
Yes. And then urgent direct access upper GI endoscopy, also within 2 weeks, should be offered for anyone with dysphagia, difficulty swallowing.
Makes sense.
Or if someone is 55 or older and has weight loss, plus either upper abdominal pain, reflux symptoms, or dyspepsia.
Weight loss plus those upper GI symptoms in that age group. Got it.
Then there's non-urgent direct access endoscopy. That's considered for someone who's actually vomited blood, hematemesis.
Right.
Or, again, if they're 55 or older with persistent dyspepsia that hasn't responded to treatment, or if they have low hemoglobin suggesting anemia, or a raised platelet count, particularly if they also have symptoms like nausea, vomiting, weight loss, reflux, or upper abdominal pain.
Those guidelines are really specific and helpful. Now, for those progressive symptoms, do we have another mnemonic?
We do. How about pain day few?
Pain day few. Okay, what's that stand for?
Pain abdominal, appetite loss or anorexia, indigestion, heartburn, nausea, dysphagia, difficulty swallowing, anemia leading to fatigue, vomiting, early satiety, feeling full, and weight loss.
Pain day fewably. Excellent. Okay, so cancer is suspected. The referral is made. What investigations happen next to confirm it?
The absolute key investigation is an endoscopy with biopsy.
The camera test.
Exactly. A flexible tube with a camera goes down into the stomach. The doctor can see the lining directly, look for any abnormal areas, and take small tissue samples, biopsies.
And the biopsies are crucial.
Crucial. They go to the lab, get looked at under a microscope, and that confirms if cancer cells are present and tells us the type of cancer cell.
What else besides endoscopy?
CT scans are vital, usually of the chest, abdomen, and pelvis. These help stage the cancer, see how big it is, if it's grown through the wall, if it's spread to lymph nodes or other organs like the liver or lungs.
Staging scans? Okay. Blood tests.
Routine blood tests, yes. Full blood count to check for anemia, liver function tests. Sometimes tumor markers like CEA or CA19-9 are checked, but they aren't always reliable, especially early on.
So endoscopy and CT are the mainstays for diagnosis and initial staging.
Pretty much. And ideally, it's a rapid access video endoscopy to get that diagnosis and biopsy quickly.
Are there any fancier endoscopy techniques being used?
Yeah, things are evolving. Some places use chromoendoscopy, where they spray dyes to highlight subtle abnormalities.
Oh, interesting.
Or high-resolution endoscopy for more detailed images. These are helpful, but maybe not standard everywhere yet. And a really important point, any ulcer found in the stomach must be biopsied, even if it looks innocent.
Why is that?
Because some ulcers can actually contain cancer or be caused by it. And you need follow-up endoscopies to make absolutely sure it heals completely.
Good point. Okay, let's talk more about staging. How do doctors figure out exactly how far the cancer has progressed?
Staging is critical for planning treatment. We use the investigations we mentioned.
Yeah.
CT scans give the big picture, looking for obvious spread, metastases.
Right.
If the CT doesn't show distant spread, then endoscopic ultrasound, or EUS, often comes next. Yeah, it's like an ultrasound probe on the end of an endoscope. It's really good for looking at the depth of tumor invasion into the stomach wall and checking the nearby lymph nodes in detail. It helps assess if surgery might be possible.
Okay, so CT for distant spread, EUS for local detail if no met's seen.
Generally, yes. A standard chest x-ray is usually done too. And sometimes, depending on the situation, you might need an MRI or even a bronchoscopy or diagnostic laparoscopy, keyhole surgery, just to look inside the abdomen.
And how does it spread locally?
It can spread through the lymph system, through the bloodstream, or sometimes directly across the abdominal cavity lining that's called transcolonic spread. That's how you can get spread to the ovaries, for example, the Kuchenberg tumor.
Kuchenberg, right. So putting it all together leads to the TNM stage.
Exactly. TNM staging is the standard system. T describes the primary tumor, its size, how deep it's grown.
T for tumor.
N is for regional lymph nodes. Has it spread to nearby nodes? And how many?
N for nodes.
And M is for distant metastasis. Has it spread to faraway organs, like the liver or lungs?
M for metastasis, TNM.
Yeah. And based on the combination of T, N, and M, the cancer gets an overall stage, usually numbered 0 to 4.
Can you give a rough idea, like stage I versus stage 4?
Sure. Stage 0 is very early, just in the lining. Stage I might be a slightly larger tumor, maybe into the muscle layer, but no node spread, no distant spread. Stage 4 means it has spread to distant organs metastasis. Stages 2 and 3 are in between, with increasing tumor size or node involvement.
So higher number, more advanced disease.
Generally, yes. It gives everyone a common language to describe the extent of the cancer.
Okay, that's clear. Now, the crucial part, management. How is stomach cancer treated?
Treatment really hinges on that stage and also where the cancer is located in the stomach.
Right.
For potentially curable localized disease, say stages I to 3 surgery is often the main treatment aiming for a cure.
Surgery, what kind?
Depends on the location. For cancers lower down, distal, it might be a subtotal gastrectomy removing part of the stomach. For cancers higher up, proximal, near the esophagus, it's often a total gastrectomy removing the whole stomach.
Total gastrectomy.
Wow. And nowadays, for localized cancer, it's pretty standard to give chemotherapy before and after surgery. That's called perioperative chemotherapy.
Chemo before and after surgery. Why?
The idea is to shrink the tumor before surgery, making it easier to remove completely, and then to mock up any microscopic cancer cells left behind afterwards, reducing the risk of it coming back.
Makes sense. Any specific chemo drugs?
A common one used is 5-fluorouracil, or 5-FU.
5-FU, okay. Any targeted therapies?
Yes, if the cancer cells test positive for something called HER2.
HER2, like in breast cancer.
Exactly, the same protein. If it's HER2 positive, a targeted drug called trastuzumab is often added to the chemotherapy.
Trastuzumab for HER2 positive, got it. What if a cure isn't possible? Palliative care.
Absolutely. If the cancer is advanced or has spread widely, stage 4, the focus shifts to palliative care. The aim here isn't cure, but to control the cancer, manage symptoms, and maintain the best possible quality of life.
What does palliative care involve?
It can still involve chemotherapy, often less intensive, to try and slow the cancer growth and relieve symptoms. Corticosteroids can help with appetite. And lots of focus on managing pain, nausea, constipation, depression, and keeping the mouth comfortable.
Going back to surgery for a moment, any specific techniques, like for very early cancers?
Yet for very superficial early cancers, sometimes they can be removed just using an endoscope without major surgery. That's called endoscopic mucosal resection, or EMR.
EMR for very early ones.
For larger but still potentially curable tumors, it's the gastrectomy we talked about, partial or total. And usually that includes removing nearby lymph nodes too, often what's called a D2 lymphadenectomy, which is quite extensive node removal.
D2 lymphadenectomy, important for cure.
Yes, it's generally considered standard for curative intent surgery to remove those nodes thoroughly. Surgeons try to spare the pancreas and spleen if they can, and increasingly these operations are being done laparoscopically, keyhole surgery.
Okay. And more on chemo and radiotherapy. You mentioned perioperative chemo. What about after surgery only?
Yeah, sometimes chemo, or chemo combined with radiotherapy, chemoradiotherapy, is given after surgery. That's called adjuvant therapy. It might be considered if the risk of recurrence is thought to be high after the operation.
Adjuvant therapy for high risk.
Right. And as we said, 5-FU is a key drug. Palliative chemo aims to improve quality of life in advanced disease. Trastuzumab for HER2 positive. And there's ongoing research into second-line treatments when the first chemo stops working.
What about managing specific palliative problems, like blockages or bleeding?
That's a big part of palliative care. If the tumor causes a blockage, options might include surgery like a bypass, gastrojejunectomy, or placing a stent endoscopically to keep the passage open.
Stenting, okay.
For bleeding, endoscopic laser therapy can sometimes be used. Blood transfusions might be needed for anemia, and pain control is paramount, sometimes using nerve blocks if medication isn't enough.
Are there any newer treatments emerging on the scene?
Yes, definitely. There's an oral chemo drug called trifluridine that's approved for metastatic gastric cancer after other chemotherapies have been tried.
Okay, a later line option.
And a big area is immunotherapy. Nivolumab is an immune checkpoint inhibitor.
Immunotherapy, right.
It helps the patient's own immune system fight the cancer. It can now be used with chemotherapy as a first-line treatment for certain advanced stomach cancers, specifically HER2 negative ones that express a marker called PD-L1 at a certain level, measured by something called the CPS score.
Nivolumab plus chemo for specific PD-L1 positive cases.
Interesting. So treatment is getting more personalized.
Exactly. It really underscores the need for a multidisciplinary team approach involving surgeons, oncologists, pathologists, radiologists, specialist nurses, all working together and following the latest guidelines.
Absolutely. So what's the overall outlook? The prognosis?
As we've stressed, it's heavily dependent on the stage at diagnosis. Early stage, found and treated quickly, the prognosis is much better.
An advanced stage?
Less favorable, unfortunately, because it's harder to treat effectively once it's spread. The UK survival stats give a general picture. Overall, about 45% survive 1 year or more after diagnosis. 45% at 1 year?
Around 20% survive 5 years or more.
20% at 5 years.
And about 15% survive 10 years or more. These are averages, remember. Individual outcomes vary.
And you mentioned ethnicity might play a role.
Yes, some studies suggest people of Asian ethnicity might have slightly better survival rates, though the reasons aren't fully understood. It could be tumor biology, response to treatment, or other factors.
Okay. Can people do anything to prevent stomach cancer? Reduce their risks?
Well, nothing guarantees prevention, but certain things likely help lower the risk. Diet is key. Plenty of fresh fruit and vegetables, aiming for that 5 a day.
Definitely.
Stopping smoking is absolutely crucial. Cutting down on excessive alcohol, maintaining a healthy weight, avoiding obesity.
Are vitamin supplements useful?
There's no strong evidence they prevent stomach cancer specifically.
And screening, like endoscopy.
The role of routine screening endoscopy for the general population, or even for just indigestion, is still debated and generally not done in the UK, unlike in high-prevalence countries. Screening is done for specific high-risk conditions, like Barrett's esophagus.
What about treating H. pylori? Does that prevent it?
Eradicating H. pylori if you had it is generally thought to be important and likely does reduce risk, although the full long-term impact is still studied.
Anything else on the horizon for prevention?
There's research into biomarkers like COX2 and whether drugs like aspirin or specific COX2 inhibitors might play a role, but that's still under investigation, not routine advice yet.
Okay. Lastly, what are the potential complications that can occur, either from the cancer itself or the treatment?
Complications can be varied. The cancer itself can invade nearby organs, esophagus, liver, pancreas.
Invasion.
It can metastasize, most commonly to the liver, lungs, or the peritoneum, that lining of the abdomen.
Distance spread.
GI bleeding can happen if the tumor erodes into blood vessels. Obstruction is another risk blocking food passage.
Bleeding and blockage.
Malnutrition and weight loss are very common due to appetite changes and digestive issues. And of course, a significant impact on quality of life from symptoms.
Yeah, and treatment complications.
Yes, surgery has risks like any major operation. Chemo and radiotherapy have their own side effects: nausea, fatigue, hair loss, lowered blood counts, and so on.
And in advanced disease.
Complications like persistent pain, ascites, that fluid buildup, and general deterioration become major challenges. This is where palliative care really focuses managing these symptoms to maintain comfort and dignity.
That seems to cover all the key areas. We've gone from definition and risks right through to complications and prognosis.
It's a lot to take in, but hopefully breaking it down like this helps cement the key information for you.
Absolutely. Understanding these details is crucial for revision. We hope those mnemonics, a GS, HDS, FMBHA, and pain day tuple are useful too.
Keep up the great work with your studies. It's challenging stuff, but you're getting there.
And remember, for more resources and practice questions, check out passthemsra.com and freemsra.com. They're excellent sites.
Definitely worth a look.
Yeah.
So just to leave you with something to mull over. Considering how difficult early detection is, especially in places without routine screening, what do you think holds the most promise for improving early diagnosis rates in the future? Is it better biomarkers, smarter imaging, more targeted screening, or something else entirely?
Food for thought indeed. Thanks for joining us for this deep dive. We'll catch you on the next one.